Thank you so much for joining us this morning. He sort of did I should just do the disclaimer, but Hilda Leon is going to take my place. I'm going to be retiring, and I'll give you information to contact her at the end of this presentation. So I am reintroducing her as the program manager for the Perinatal HIV Prevention Program. Our title is obvious to you: protecting your patient, her baby, and yourself. And I want you to know that I have I'm not clicking on the right things. Oh, excuse me. There are no financial relationships involved with my role. All of these slides are peer reviewed, and the information is accurate and up to date according to the perinatal recommendations for prevention of mother-to-child transmission. Our program is also based on the Florida statute for testing. So this is just the goals, not only for the talk, but also for our program. So obviously we just want to see that all the babies that are born in the state of Florida are not going to be HIV infected. And so the protocols that we follow, the orders that hospitals have established are with that goal in mind. And you can see the objectives here. Most of you that are watching are already really aware of what the objectives are. We just want to make sure that everyone knows that women are to be tested first and third trimester, or the initial visit during her pregnancy for women that are pregnant throughout the state of Florida. We want to increase the number of providers that do routine testing during pregnancy. We want to increase the number of hospitals that do rapid screening if they don't see testing. And we're going to talk about that some more, okay? And maybe we're going to move on. There we go. All of this is based on the CDC's advancing initiative to prevent HIV. And the next two slides are definitions involving HIV. And I usually, when I'm doing this as a face-to-face, I ask, what is the testing that's done during pregnancy? What category does it fall under? So I'm going to give you the answer. You should probably know. It's screening. And the reason is that all people within a defined population are to be tested. Our defined population, obviously, is women that are pregnant. So that's the definition that we are most concerned with here. In the state of Florida, we are an opt-out system of screening. Up until 2006, women had to sign a consent in order to be tested during pregnancy. Now, like I said, 2006, our system is opt-out for screening, and women have to say if they don't want to be screened. What we suggest is that providers say we routinely test for STDs and HIV during pregnancy. Make it matter of fact, and if the woman wants to decline the testing, then she needs to sign a refusal form or a form of some type. It doesn't matter. If she doesn't want to sign, then the doctor needs to document it in the chart. So that's the opt-out system. It eliminates having to do pre- and post-test counseling. This is just a slide on global summary of AIDS. I apologize that it's 2014. I don't have the same data for any more recent than that, but it does give you an idea of where we are globally. I can tell you that over the last couple of years, and the difference in the number is on this slide, we have dropped the number of women that are living with HIV in the United States, and it used to be one of the greater risks for death, or the most frequent. I think it was number 5, and now we're down lower on the scale. So we are getting better, but it's because we have better medications. In the state of Florida, you can see some of the statistics more recently, and you will see that 91% of women that are HIV positive still report that they are heterosexual contacts. So this gives you a little bit of insight into what we deal with within our state. And these are risk factors. I think each of these are very important. We know that women that are HIV positive and have another STD, very often there is co-infection. If we see STDs, positive screening during pregnancy, but we don't see HIV, shame on you. What we're doing DOH wide in the state of Florida is if you're screening for STDs, you should be screening for HIV. About 4 or 5 years ago, that wasn't always the case. But now I think we're doing a much better job of screening for HIV when we screen for STDs. It is an STD. If there is the presence of an STD, their immune systems are compromised. Sometimes membranes are broken down. The risk of getting the virus transmitted is going to be greater. The stage of the partner, that's a really critical issue. If he or she, that partner, has a very high viral load, that's the amount of virus in the body, then the risk is going to be greater for transmission because there's more virus that can be transmitted. Substance abuse, social behavior, I kind of lump those two together for very obvious reasons, because it is a very social behavioral thing for people to be substance abusing, whether it's alcohol or drugs. So I usually put those two risk factors together. Age, because we know teenagers think that they're invincible and that nothing's going to happen to them, so that makes it a factor. And we know that that is a huge factor among teens that are sexually active because they believe that they're impervious to any disease, which would include HIV. Exposure site is important. We know that the receptive partner is usually a little more at risk. And in the case of a heterosexual contact, that's going to be a woman who's possibly able to get pregnant. And so she may progress through the disease more rapidly than her male partner. And so this is another risk factor. Membranes break down and the virus crosses those barriers. The role of contraception is on here. And I think if you think about that little caveat that you see on TV ads about birth control, very often you'll see in small print at the end of the ad, this does not protect against HIV and AIDS. People truly believe that contraception is all they need to be thinking about. They forget that they need to be protecting themselves from HIV and other STDs. And the only way they can do that is to use a barrier method of protection, so male or female condoms. So this role increases risk when we are not thinking about these factors. So we want to present that to our young adolescents, and we see a lot of HIV transmitted at all ages. So it needs to be something we consider. As far as pregnant women are concerned, these were revised recommendations. These are that it would be a routine screening for these people, that women are screened during pregnancy, first and third trimester, that we repeat it. That's an opt-out system. You can see that each one of these items on this slide are items that we follow in the state of Florida. So we have done those things that the CDC recommended for us to do. Not only the CDC, the World Health Organization, and MMWR, and the National Institute of Health, they all go along with these recommendations that are on this slide. This slide is of critical issue because it is the way people who are HIV positive may or may not respond, and what we see as a result in numbers of infection. So I want you to look on the left side at the circle, and you'll see that of the people that are aware of their infection, of all people who are infected, 75% of them are aware that they are infected. And those translate to less than half of new infections. But a quarter of the people who are infected who are unaware of their infection, that 25% is responsible for more than half of the infections. So the theory behind this slide is if you are aware that you're infected, you're going to try to prevent transmitting the disease to someone else. So this is talking about sexual contact, but it's also talking about women that are pregnant. Because if they know they're HIV positive, they're going to want to protect their babies in most cases. We'll talk about some of the factors that keep that from always being the case. All right, the objectives for preventing mother-to-child transmission is the same as the objectives that we have for this program, for this presentation today, and for the Perinatal HIV Prevention Program. And I'm not going to read the slide to you. The way that we have begun to eliminate perinatal HIV in the state of Florida, all of these orders and protocols began with the PACTG 076, which was the clinical trial done back in the mid-90s. And when you look at the slide, you see a little mountain. And the mountain is how high our numbers became in the state of Florida for HIV to be transmitted from mother to child. And in the 90s, late 80s, we realized how critical this was. These babies were being born infected. The scenario for them was very poor. There were not a lot of drugs available to use to help these children with their disease. And many of them, the majority of them, died by the time they were 2 to 3 years old. So Pediatric Infectious Disease realized the need for a research trial, and the 076 was begun in, as you see, 93 and 94. It really was to be a 2-year study, and after about 9 months, and they reviewed the data, it became the benchmark that it is today, because they could see how successful it was in preventing the virus. The other bullets that you see on our mountain are of historical factor, which includes the Public Health Service issuing guidelines, releasing guidelines. It includes in 1996 that the CDC recommended counseling and testing for all pregnant women, and that in October of 96 that mandatory offering became law, of testing became law. And then in 2006, in the state of Florida, routine testing became law. Now, what we need to remember is that our law says that providers are to cause women to be tested. The law is still not that all women will be tested. So our goal in doing education is to see that providers are making sure that their patients are tested. And some of it is often because of the way they present having the testing done. The worst case scenario is a provider that says, you don't want to be HIV screened, right? The best scenario is, I think I used this sentence already, that you routinely screen for HIV and STDs. It is a fact. We are going to do this unless you tell us not to. So we want them to understand what's going to happen. They're having a lot of blood drawn anyway. Let's just go ahead and draw for testing. All right, this map here is of HIV positive perinatal exposures in the state of Florida, beginning when we first started counting, which was after that full year, which when the opt-out system started in 2006. So the first full year of record taking was in 2007. So you can see that delineated by that sort of olive green. And then we moved down. In 2007, notice there were 17 identified perinatal HIV positive children born. And I will tell you that these numbers have changed according to maybe these kids weren't identified until they were 2, 3. I've even known of children not identified till they were in their teens. But those numbers have changed according to what was identified and their year of birth. You can see that we were very much able to prevent transmission of this virus. All the way into 2011, our numbers kept dropping because we were testing and we were identifying these children as positive. But then we've started to see an uptick in the number of births that have resulted in HIV positive children. There are several things responsible for this, and I'm going to talk about that a little bit in the next couple of slides. But it is that much more important that providers realize we are still seeing HIV positive infants, and we need to be testing women. We need to be making sure that women are tested either first trimester or during their initial visit, and again during third trimester, and that women are linked to care. You can see in 2015 we had 9. I will tell you, this doesn't make that number any better, but we had a set of twins that were born December 31st of that year. So that just went on top of that number that we were already very unhappy with. Every HIV infected child is a sentinel event. Our program is responsible to go out and make sure that hospitals are aware of what they can do to prevent a positive child and who to connect these mothers and infants with for screening. This is a great responsibility for all care providers within our state, is to make sure that we identify children that are HIV exposed and help prevent these children from being positive. All right, we're going to move to the next slide, and these are some of the obstacles. These are some of not only obstacles to eliminating perinatal HIV, but some of these reasons are the reason that we have also seen an uptick in HIV positive children in our state. I want to also refer to our website. On our website, we have a webinar that we did just a few months ago, done by Mary Jo Trepka. It is results of research that was done on these infants that were positive from 2007 here in the state. And it gives you some facts about those children and why, the factors that contributed to them being HIV positive. So when you're finished today, or when you have a moment, go to our website and click on the link that's there. If you don't see it, wait another maybe 48 hours. We were having some problems with it showing up on the website, but when you see it there, it's our YouTube account. It will take you to the YouTube account, and then it will take you to the link containing the webinar, and you can see her presentation, not just the slides, but her presentation. So it'll give you a little more insight into those children. I interrupted myself, but that's okay. We're going to go on to these obstacles because that's part of that data that's in her webcast. Obviously, the things that contribute to an increase in infection among women is because we're having unprotected sex. We also see a lot of absent and delayed prenatal care. And we see this because women are using some type of illicit drug. They're substance abused, and we know how demanding their drug addiction can be. They avoid going in for care because they're maybe avoiding authorities, and they associate the medical profession with some of the governmental authorities that they're trying to stay away from. What they don't understand is that they're not protecting their child. So you see some of the other contributing factors or risks that have made obstacles to preventing mother-to-child transmission. We like to keep women in care. We want to link them in care. Those of you that are out there that are perinatal coordinators, you try to establish really good rapport with your patients, because that often is what helps them maintain attending their appointments and adhering to their medication. You want to be their partner as far as their medical care and their infant's future is concerned. So we want to continue to keep these obstacles ahead of us so that we have a prevention level there. I'm going to talk a little bit about the acute phase of the disease, or the natural course of the infection. This slide can be a little deceptive, so I want you to concentrate right now on that purple line. It would be inaccurate if we said that the acute phase of infection jumps up to about 1,000. For purposes of this slide, it stops at 1,000. But if you could imagine it jumping out of your screen, going straight up to your ceiling, that might be a little more accurate, because during acute infection, the viral load, the amount of virus in the body, which is what we're talking about here, also called the HIV RNA, is going to be even into the millions, and you have a lot of virus at that time. And then it levels out within the first 3 to 4 months, and then we go through an asymptomatic period. There is no reason for the person to believe they were HIV infected. They don't remember those very nondescript symptoms that they may have had when they first contracted the disease. And so for them, because they don't have any symptoms, they may go as long as 5 or 6 years before they're in medical care. Now, in the case of a woman who's pregnant, this is a very dangerous time to get pregnant. Suppose she gets pregnant at the same time she contracts the virus. She and her baby are going to have the effects of this extremely high, remember I said, can be in the millions, viral load. And so the risk of that baby contracting the virus in pregnancy becomes very, very high. It's a very dangerous thing for the baby. If mom is infected during pregnancy because she's having sex with a partner who's infected, but she's not using any type of barrier contraception or barrier protection, then that can be a great risk, because that baby, while in utero, is exposed to mom's really high onset of the virus in her body. And so she's exposed to these very high viral loads. So we need to be telling our providers in the area to remind their patients that they need to be using barrier contraception if they're having sex with multiple partners or a partner that could possibly be HIV positive. And I'll talk about why that's so critically important. But you can see what happens if infected during pregnancy, or if infection and conception occur at the same time. All right, the next slide is going to jump to, I've moved it off the dot, sorry. This is our CD4 or T cell level, and this shows you what happens to it. This is that level of protection that your immune system has. When we are talking to someone who's HIV positive, there are 2 parameters that we teach them about that are very important, not only to the medical provider, but to the patient. We make that important by explaining to them that the amount of virus in their body is critical to how healthy they're going to be while they are as they are HIV infected. We're also going to talk to them about their CD4 count, because that is an example of what their immune system is like. So their CD4 count is going to drop when the viral load is a little higher, and then at the onset, it's going to start to level out. The body starts to handle the virus for a little while. What we find in the state of Florida is that many people that are HIV positive, and I'm talking about people that are not pregnant, because we want to be screening during pregnancy, but many people who are HIV infected are not identified until later in the progression of the disease. They are no longer in that asymptomatic phase, and that's when they go to the doctor because they're starting to feel bad. So we see more and more infection identified at 6 or 7 years into the course of the disease. Now, if a woman is pregnant, that's why we're doing the screening, so that we have a chance to use these highly effective antiretrovirals and watch the virus drop and the risk of the baby drop. So, getting back to our data here, our slide, you see what happens when the virus starts to get more prevalent through the body and the CD4 count starts to drop, because we know HIV attacks these cells. It ruptures them, it destroys them. The body is not regenerating them. And so this is a very ill person, and now we start to see opportunistic infection appear. And that's why, if they haven't been screened before, people are starting to get sick. They're starting to see infection with maybe some yeast, or they're starting to realize that they're TB positive. And then we start to question what's going on and do HIV screening. We don't want people in the state of Florida, especially pregnant women, to wait until they're symptomatic. We want to screen them so we get avoid the risk of virus being so prevalent and the immune system being so destroyed by this virus. All right, these are the results of the 076. What they found, and this stands true today, that if they're not identified and treated, then you're talking about a 25 to 35% risk of virus being transmitted from mother to child. Now, the reason there's a range there is it is dependent on how much virus is in mom's body and how sick she is. If she's at the peak of infection, then the risk is going to be greater to the baby. In the absence of breastfeeding, you're looking at a 30% risk of transmission occurring in utero, so while mom's carrying the baby. In the absence of breastfeeding, a 70% risk of transmission during the time of labor and delivery. So we know that during labor and delivery, women are exposing their babies to their blood. That's part of the birth process. So this is one of the reasons in the guidelines they say that if we have a woman with an unknown status and we don't know how high her viral load is, then it's recommended that that woman's experience a C-section to deliver her infant, because then we remove some of that blood. And it is exactly due to the 70% higher, or 70% transmission during delivery. We want to eliminate some of the blood that this baby's exposed to. And you put on top of these factors the additional risk of breastfeeding, you can see that it's going to increase by 14%. Now, when you put that with unidentified HIV in the mother, and maybe she's ends up delivering vaginally, now you're talking about an over 50% risk that that baby's going to acquire the virus. So these factors are all very, very important, especially when you're talking about breastfeeding and when you're talking about breastfeeding with primary infection. So this is I don't even need to read it or say it. You know, we don't want to breastfeed. So women that are breastfeeding, they need to be aware of their HIV status. And so I tell people that are working in hospital staffs and in providers' offices to mention to their patients that, especially those that maybe have decided they didn't need to be screened during pregnancy, if they're going to breastfeed, they probably want the assurance of a negative HIV screen. So there's another reason to do it. This slide, a lot of people think this is really negative, but the guidelines have begun over the last few years to include that education about pre-mastication during pregnancy is very important when it comes to HIV infection. And the reason is that we have had children that were HIV infected, and the only way they could have been infected was because their caregiver was pre-chewing the food. There have been celebrities that have purported that that's what they do for their infants, and we know especially young adults and teenagers are very influenced by what celebrities do, so that's increased the risk of mothers thinking they can pre-chew food. Or mothers have caregivers that they really trust. Maybe it's a grandmother or an aunt or some member of their peripheral family or their friends that they've trusted so much, but that they have never even considered telling them what to feed their infant. And maybe it's a cultural thing. We see a lot of cultural influence in pre-chewing food, especially from the Caribbean, people from Africa. They are pre-chewing food and giving it to their infant because that's what they've always done. So we need to encourage our women that are delivering babies to make sure that they dictate what their babies are being fed. I do this presentation for college students, and I tell them to not only for their own use, but for their patients, to encourage them to be the ones that provide and dictate what their children are being fed. Now, what's listed here are 3 of the very first documented cases. And the reason the infection was found during testing, because these babies were sick and they couldn't figure out why they were constantly sick. Maybe it was repeated ear infections or some other type of infection that they just couldn't clear. So they were testing the baby, found that the baby was positive, but mom and dad were negative. And it was during that time that they tested the caregivers. They went back and did research and found out that the caregivers were positive, and they were pre-masticating food and offering it to the infants. So we need to make sure that our patients are very aware of this risk. There have been several other babies infected. I don't have good documentation on them, so I don't have all of it on this slide. But I do invite you to go to the link on our website and obtain the perinatal guidelines. You can use the outline feature, which will show up on the left side of your screen when you link it. And you can just get to the table of contents and go to the part about pre-mastication, and you'll see more information about why this is so critically important. Okay, these are the key components of preventing perinatal HIV from, in other words, mother-to-child transmission. We want to do testing. The sooner we know that women are HIV positive and pregnant, the sooner we can start medication, and the sooner we can prevent the virus from being so prolific that the baby acquires it. So we want to do that. We want labor and deliveries to do rapid screening. Rapid screening means that that test result is available within 30 minutes or less. So we want good, solid, rapid screening done in our labor and deliveries. And you may want to check your hospital and make sure that they're doing the screening that results quickly, but it also includes generation 1 and 2 of HIV, because we do see some 2 here. I'm going to talk about that a little bit later. We want HIV to be identified so that during the pregnancy we can give the antiretrovirals. During labor and delivery, antiretrovirals are offered. That includes hanging the bag of AZT during labor and delivery, and it includes making that decision about whether or not mom is going to be C-sectioned or have a vaginal delivery. Now, the guidelines say that if a woman is I'm going to jump ahead of myself. I'm not going to say what I was going to say. The guidelines originally were if the viral load was less than 1,000, then a woman didn't have to have a C-section. She could deliver vaginally. That's changed a little bit. I'll talk to you about what the recommendations say and what our pediatric infectious disease doctors say in our state. We want to see that these women and their children are linked to care. If they can be linked to care during pregnancy, then we know that, like I said, we're going to encourage them to go for their appointments. We're going to encourage them to take their medication. We want them linked to care so that the infant follow-up is done. The testing is done at the correct intervals, and that we can verify that the baby truly was negative. And we want our hospitals to use universal precautions. And like I said, we want to do the prophy with the antiretrovirals, and we'll move on. This is the law in the state of Florida. It is Administrative Code 64D-3.042, and it was released in November of 2006. And this is at the time that we became an opt-out state. And you can see that this was supported by the American Academy of Pediatrics and a position statement also by A1. There are many other organizations that are national and international that have also gone on to write position statements on prevention of perinatal HIV. In our state, this includes screening for these 5 viruses. So we're talking about chlamydia, gonorrhea, hepatitis B, HIV, and syphilis. All of that needs to be done at the first prenatal visit. It needs to be repeated between 28 and 32 weeks. That would be your 3rd trimester testing. I will tell you that I usually instruct that we are better to do the testing 32 weeks instead of 28, because we have had a couple of children that were HIV infected in our state that the screening was done a little too early, done at 27 weeks and 5 days or 28 weeks. Mom was having sex with multiple partners, unprotected sex, and the virus was transmitted. She went through that time period of very, very high viral load, and her baby ended up being infected, and her tests had both come back negative. This is a very bad scenario, and this is why I'm asking you and begging you to please make sure providers are talking about barrier protection during pregnancy, especially when we're talking about women that are having multiple partners during pregnancy, because the testing may still come back negative, because what we're testing is the antibodies. I usually say that with that black slide with the colored lines. But we're testing for antibodies, and those antibodies have to build up as a result of being infected. And it may take up 40 days or more for that to show up in a test. Our testing has become more and more exact over the last few years. And what we're saying now is if you're infected about 40 days, you're probably going to have a positive screen because you're going to have enough antibodies to show up. But it is still an iffy situation. So let's use barrier contraception or barrier protection when we are talking about pregnancy and having sex with multiple partners. Okay. I got sidetracked again, and I apologize. The law also requires, if a woman comes in labor and she's within 30 days postpartum, and you have no knowledge of any testing done during pregnancy, then that needs to be conducted. And we're going to talk about notifying her. And you're going to notify her, and you're going to document if she objects to have the testing. And if she refuses, then it's up to the providers to see that it's noted in the chart. Then we're going to talk about the risk, obviously, is not knowing. I have jumped ahead to some of my other information about the law, and I apologize. That's why I got off track. We're going to talk about antepartum care. We want them to take the medication. When I started in HIV over 25 years ago, there were about 6 drugs out there that were available. Now we're talking about over 100 drugs that are available. Certain drugs are better during pregnancy than others, but the goal of taking antiretrovirals is to lower the viral load so that we can keep it undetectable for as long as possible. And the only way that we're going to do that is for mom to consistently take her medicine, stay in care, and for us to be doing screening about her viral load and her CD4 count during pregnancy. We usually advise, and the guidelines indicate, that those tests need to be done at least 3 times during pregnancy. We want to ensure that mom is there to watch her infant grow and develop, and to be available to take care of her child, to give her that opportunity to have that quality of life that she deserves. HIV today can be treated as a chronic illness, as you would treat diabetes or hypertension, if the individuals stay in care. We can restore immune function, that CD4 count that I was showing you that line for. We can see it reconstitute if we can keep the viral load down. And so we want to do that because then they can fight all these other infections that are available to them and that they may contract if their viral load is real high. All right, let's move on. These are the care, talking about the care guidelines. And I talked to you about how important it is that we know what the CD4 count is in an HIV positive person. It's also even that much more important during pregnancy. We want to monitor their CD4 count and their viral load. Then we can make decisions about the method of delivery. If her viral load is below 1,000, there is no reason as far as her virus is concerned. There could be an obstetrical reason for her to have a C-section, but it isn't going to be a result of her being HIV positive. And obviously, we want them to take their medication. The guidelines also include referring for support services. The state of Florida has many services available to women that are HIV positive and pregnant. We can provide medications for them. We can provide housing for them. In many areas, we have TAPWA available, which is the targeted outreach for pregnant women with AIDS, and that offers many services, including case management. We have a lot of areas within our state that offer care coordination and link women to care. But if a woman's not identified until she is in labor and delivery, then it's up to the hospital to see that the right people are brought into the scenario so that they can connect the patient to care. So the hospital has to do that little bit of linkage and then let the providers and TAPWA take over from there. All right, we want to discuss long-range plans for care and treatment because we want to see women that are identified positive during pregnancy to stay in care. And often what happens with a woman that delivers a baby, whether she's positive or not, she's tired, she's thinking about that child's health, and we tend to put our own health on the back burner. When a woman is HIV positive, we don't want that to happen because we need to make sure that she stays healthy and her virus is controlled. All right. In the emergency department, there is a responsibility due to that statute that we talk about in the state of Florida. And we want women identified that are that have had no prenatal care after 12 weeks and they come into the emergency departments. We want them reported to the local DOH. And it needs to be in writing, and it needs to happen very quickly, all right? And I've got those parameters for you. We want a copy of that referral sent to DOH, and we recommend in the emergency room or in labor and delivery, depending on where this patient is seen, that rapid screening is done. So before she walks out the door, she knows if she's had a positive screen. And I want to add to that, any positive screen needs to be followed with a confirmatory test. There always needs to be another serum test done to confirm that that wasn't a false positive. It doesn't happen often, but it does happen. And you certainly wouldn't want to be identified HIV positive and not have had a second test to confirm. So I don't care if you're pregnant or not, all tests need to have a second test. Okay. Moving on to the emergency department response. If you've got a woman with no prenatal care that shows up in the emergency room, then we're going to do that rapid screening. And again, we're going to report it to your local surveillance office. Intrapartum care. Now, this is the caveat that the guidelines changed back in 2014. I was in several meetings with physicians that were pediatric infectious disease here in the state of Florida, and they were all very upset about this change to the guidelines, okay? And what they said is you could consider not offering the zidovudine, the ZDB is the same thing as AZT, if her viral load was less than 1,000, and you had confirmation that she had been taking her medicine during pregnancy. Now that means that you've got a viral load and a CD4 count that's less than 4 weeks old. That's the only way you're going to know this. And these physicians all said, we don't want that to happen. Just hang the bag of zidovudine or AZT, because that way we know we've covered it. We haven't been dependent on a lab result that maybe the date's wrong on or that it's incomplete information on the prenatal chart. There's a lot that goes on in labor and delivery. Many of you are very aware of that. It is too easy for there to be a mistake. So the instructions that we have from our own pediatric infectious disease physicians in our state is just go ahead and hang the bag of AZT. These patients that are HIV positive and have already been taking antiretrovirals need to go ahead and take their oral medicine during their labor and delivery, okay? The bag of AZT is a loading dose to protect the baby, and it will be administered. And the dosing for that can be found in the guidelines, but it's like a bolus dose in the beginning for the first hour, which is 2 milligrams per kilo, and then in every hour after that, it's going to be 1 milligram per kilo. If we are able to, we would like to see more than 2 hours of that medication administered to a woman who's in labor. All right. And a C-section is recommended if it's less than 1,000 copies. There has been not a strong recommendation, but at some point we have seen recommendations that are saying less than 500. And those same pediatric infectious disease doctors have said, no, we're going to adhere to the less than 1,000 because it's too easy for the timing of labs to be incorrectly documented. Now, testing for women who present in labor with an unknown status, that means that they're going to have a rapid screen, and it needs to also have that pending confirmatory test, and they should go ahead and be given their zidovudine IV, and then it is recommended that prophy also be given to the baby for the first 6 weeks of life. Okay, so that's another very important part of our guidelines to help prevent transmission to the infant. And I can tell you in my own experience, I've seen infants protected because mom was identified by screening done in labor and delivery. And the zidovudine was hung and mom received it IV, and then the baby received the 6 weeks of prophylaxis, and we ended up with negative babies. So it does work. And it is a result of that 076 research and subsequent research over the years. So I just want to call your attention to that. The HIV transmission and a C-section delivery, we like to see a schedule to know when delivery is going to occur. And I realize that our perinatal quality collaboratives want us not to deliver babies too early. In the case of HIV, we are going to be a little more aggressive with either scheduling induction or arranging for a C-section depending on what viral load is. So we realize this is pushing that time limit that we're trying to get away and have babies that are not premature. If mom's been in care, there's going to be a little more assurance as to how this baby is developing and the risk that we might be taking. For women with an unknown viral load, we're going to be doing the C-section. That's what's recommended, and we're also going to encourage that all of the measures are taken to prevent transmission to the infant. Now you see that same caveat there about the 1,000. Maternal risks by mode of delivery, you're going to counsel women that are HIV positive what could possibly happen. For years, we had people with that rumor that if you were HIV positive, all women were going to be C-sectioned, and it isn't a necessity. And you need to point that out to your women that are identified HIV positive and pregnant because they're very anxious about it. They want to have a vaginal delivery most of the time. They want to be in care. So I want you to explain to them that as long as they can keep their viral load down, that's another reason for them to stay in care and to take their medication, then we're not talking about a C-section for them, okay? Complications of a C-section need to be weighed against the risk of transmission to the infant. Very often, this is very invasive. It is major surgery, and infection is a possibility. So if the woman's viral load is low, then that's one of the reasons that we're happy that she doesn't have to have a C-section, all right? Obviously, if she has a C-section, we're talking about using some antibiotics to help prevent infection. Other intrapartum management issues are listed here. Obviously, you can see all of those things you want to avoid, and that's because you're exposing the baby to maternal blood. And you need to consider interactions with the antiretroviral and drugs that are used to prevent uterine atony. All right, postpartum management. Now, when we talk about postpartum management, we're mainly talking about the newborn. But I want you to kind of note here that follow-up needs to be coordinated between the HIV specialist and the OB during pregnancy, and then as a follow-up for the mother that's pregnant. I just had a baby that we identified here in the state of Florida just a couple months ago that she went for her postpartum appointment and they were getting ready to put her on birth control, and she identified to the DOH worker that her child was very sick and in the hospital. What happened was the hospital had not done rapid screening, and mom was positive. She had delivered a positive child. She was not in care herself, even postpartum, and it wasn't until she went for birth control that the message made it, and people started trying to rapidly get her linked to care, and it was already too late for her infant. So don't think just because the education has been presented that it has been delivered appropriately. This is why we have to continue to talk about these issues. All right, women with a positive rapid screen, all of that is what we've already discussed. We need to, again, talk about restrictions on breastfeeding, okay? I'm going to move to the next. The care for the infant. Now, there's several things here that are very, very important. We're going to initiate the antiretroviral prophylaxis for the infant. Over the years, we've reduced the number of doses and increased the dosing so that infants only need to have that medicine every 12 hours. It's made it a little bit easier for mom, but we don't want that baby born and if mom's testing is positive, we want to start the antiretroviral liquid AZT, so to speak, or zidovudine within the first 12 hours of life so that that baby has the protection of having had that medication. We're going to do a confirmatory test on mom, and we're going to have that antibody test, the DNA test done on the baby, and we call that the birth PCR. So that we've got that very first time we've screened the infant. Sometimes patients don't come back for care, and we're very concerned about that, and we need that first test done. We're going to also continue with prophy for the baby for the first 6 weeks of life. If the child's DNA or that birth PCR is positive, then that medication needs to be stopped, and we need to refer to a pediatric HIV specialist. Now, for any infant that's on prophylaxis, and now I'm talking about the infant that we believe is exposed, not positive, we're going to do 6 weeks of the zidovudine, and the guidelines, that same 2014 set of guidelines came up with this caveat that if there was confirmed evidence that mom had taken her medication during pregnancy and that her viral load was low, then we could consider only doing a 4-week course of the medication. And those same pediatric infectious disease physicians said do 6 weeks of prophylaxis. So sometimes infants are become anemic, and that's one of the reasons that we want to do that CBC the same time we do that initial birth PCR in the newborn state, right after the child's born. Because zidovudine, that's one of the side effects, is that you end up with children that are anemic. In my experience, if they weighed less than 6 pounds, that seemed to be those were the ones that were anemic from the AZT. Usually they're going to be monitored. They're going to be monitored not only by the hospital with that baseline, but then when the child goes for their 2-week visit and another PCR is drawn, they're going to do another CBC and see how the baby's handling the medicine. If we are seeing a little bit of anemia, the doctor can make the decision. Usually they'll go ahead and keep them on the medication and do another CBC at 4 weeks if it's suggesting that the child's going to become anemic. At that time, they may stop it because of the anemia. But I have seen many children that have been protected by the antiretroviral, even though it was 4 weeks. even though we do prefer, and I'll say it again, to have 6 weeks of the liquid AZT. It's easy to administer, and we know that it does protect the child. We're also going to do testing of mom to make sure that she's resistant to medications or not resistant. You may find that your patients have shown some resistance to zidovudine, and the guidelines and our research prove that we still want to have zidovudine as part of the regimen. That was the medication that was used in that benchmark 076. That is the medication that we know helps. We do use combination therapy because each of these medications acts on the virus in a different way. So that's why we use a combination therapy we call HART, highly effective antiretroviral therapy. But zidovudine should be one of those elements within that therapy. When we're talking about the dosing for infants, if they are premature, that dosing is listed in the guidelines, and you can pull that up on our website. There's a link, and you can see what that dosing is. And our hospitals are also aware of that. In the United States, if antiretrovirals other than zidovudine are recommended, then we don't have good data on what the dosing should be for those medications. So we really like to stay with our tried and true methods. Now, in an infant that's born to a woman that was not on medication, who is identified positive in labor and delivery, now we have a reason that we need to add another medication to protect that child from the virus. So, and this also is important that we add this medication in a woman whose viral load is very high. Maybe she's been in care, but she hasn't been taking her medicine appropriately. She's been inconsistent with her care. Then we're going to probably opt to do nevirapine for this baby. So your combination antiretroviral therapy regimen is listed here. They're going to have the zidovudine, but they're going to also have 3 doses of nevirapine. And over the years, we've changed the dosing. It used to only be 2. Now it's 3. And the reason is that this is a very toxic drug. And we've spread out the dosing to help prevent the mother from, this child from developing resistance to this drug if the child were to end up positive. Because what happens is they don't develop resistance only to this drug, but an entire class of antiretrovirals. And if they're positive, that can be restricted as to what we can use to promote their health. And so we don't want that to happen. They've spaced these out, and you can see it listed there. At birth, 48 hours later, 96 hours after the second dose. What I find in the most effective medical systems are hospitals that keep these babies in the hospital until they've completed that 3rd dose of nevirapine. Every once in a while, you see a physician send mom home with the dose for that 3rd dose. Because it is so specific to when this dose is offered, these doses are offered, we really prefer that they remain in the hospital. But that is a medical call. It is not a nursing call. Now, I want to throw this in here. A lot of people say, well, I know in Africa they're using nevirapine and women are breastfeeding their infants. Yes, that's absolutely true because they don't have access to pure water and they don't have the good medication or the good formulas that we have here. And so they are breastfeeding, but that means that mom and the baby are on nevirapine as well as the AZT, and now you're running a risk of resistance. I see that I'm getting over time, so I am going to move ahead a little bit. Here is your management of the HIV exposed infant, and this is the parameters for the virologic testing, and that we're going to add a prophy of like Septra or Bactrim in the case that we don't have these tests done. I used to use that as a reason mom needed to make sure she took her child to have the testing done. This is the parameters for the law that report that it needs to be reported. Providers have this responsibility. Labs have this responsibility. And it needs to go through the Department of Health, your local Department of Health. Labs usually report, and these positive tests are reported up to Tallahassee, but this is a stopgap measure. If we do it ourselves and we call our local DOH, then there's 2 people reporting, and then maybe we keep somebody from falling through the cracks. In the summary, I have this little cascade here I want you to look at, and it's talking about the things that we need to do to prevent it, to prevent perinatal HIV. We want to use safe feeding practices. Remember the pre-masticated food? We don't want to do that. We want to identify what's safe for mom to do for her infant. We want the babies to receive the medication. And I'm starting at the top instead of the bottom, so I'm backing up. We want mom to go for her appointments. We want to make sure in labor, in her prenatal care, that she's offered testing during her initial visit and again in her 3rd trimester. We want to make sure she gets those test results. We want to make sure she's on medication. We want her to accept taking the medication, which that's where our coordinated care is so important, to show her how to take them, how to prevent herself from getting sick with them. And these drugs usually don't cause a lot of side effects by the time she's in her third month of pregnancy. We want the baby to get the medication, the prophylaxis after the child's born, and we want to talk about safe feeding. So I apologize. I haven't used that slide yet. It's brand new and I wasn't paying attention. All right. Early identification is the key. We've already discussed this. Please pay attention to this slide. These are the components of comprehensive care. We have a lot of services. We want to make sure they're linked to care. We want to do something about substance abuse and offer whatever support is necessary for our patients. In the state of Florida, Walgreens that are near delivering hospitals have partnered with the Florida Department of Health, and we offer liquid AZT in those areas that don't have some other method of presenting it to mom before she leaves the hospital with her infant. Some hospitals will provide it through the center part of the state. They've got a system and mom does it, automatically, and they don't have to depend on this. The Baby or Express program is for the more rural areas where there is no way to get liquid AZT because it doesn't have any shelf life. Many drugstores, most drugstores don't keep it. And so if mom shows up with a prescription for AZT, they're going to say, well, we can't get this for you for the next 2 or 3 days. Baby's not getting the meds, and the protection for the baby is gone. We don't want to go more than 12 hours without a dose of AZT. So that was when this partnership was developed. If you are in an area where you would like your local Walgreens to tie in with this DOH policy, please contact the Perinatal HIV Prevention Program, and we will see that you get the information to do that. You can see how effective this is, and we've been able to offer this medication, which isn't really expensive, but if you don't have the money, you've got to have a way for it to be paid. We have many patients moms that deliver that don't have any type of insurance, and the baby's Medicaid may not kick in for a week. You've got to have a way to get that AZT. This is the answer to it. All right. These are the contact and link here is Hilda Leon. Many of you may know her. She's coming back to our program as the program manager and the clinical educator. There is her contact information. It is the same phone number that we've had for these last 4 years, and she will be happy to answer your questions and provide education for your organization. These are contacts if you're in Southeast Florida. That information's there. If you obtain our slides, you will get that information. I know you're not going to have time to write it down right now. If you're in the center part of the state, these are the individuals that you're going to want to contact. These are these are the coordinators of care that will see that your women are followed during pregnancy, that will see that the babies are followed for testing and for follow-up. All right, please visit our website, visit our Facebook page or our Twitter. We are interested in hearing your needs and your scenarios of care and giving you whatever educational support we can. Thank you so much for joining us today. The next slide is resources that were used to provide these slides for you. We're going to have a brief time for question and answers. I know that we're over schedule a little bit, but if you would like to send us a question, you can type it in. I want to remind you that you need to send Hilda your RN license number, your email address, and your name so that we can send you the link so that you can get your CEs. Okay? Thank you so much. I don't see any questions right now. I hope that you'll take advantage of the email address. You can always email us when you have questions. All right? And thank you.